There is one specific shape, one particular appearance, that if you have been seeing it in the toilet over the past few weeks and dismissing it as nothing, may be the most important detail I tell you today. It doesn't hurt, it doesn't bleed, it doesn't announce itself with pain, fever, or any of the symptoms we typically associate with something serious. It simply continues to appear quietly, day after day, and most people who notice it assume it's probably related to something they ate and move on. Some of them are right, some of them are not. I'm Dr. Mandel, and I have been practicing medicine for many years, working extensively with older adults. I have sat across from countless patients who came in for something entirely routine, a blood pressure check, a follow-up appointment, or a prescription renewal, and almost as an afterthought mentioned that they had been noticing something unusual in the bathroom for quite some time, but weren't sure it was important enough to mention. And I've had to look them in the eye and say, that was absolutely worth mentioning. In fact, that was the very thing you should have brought up much sooner, not because I was trying to alarm them, but because it was true. Here's what I've come to understand. Your digestive system leaves behind a physical record of what is happening inside your body every single day. Color, consistency, shape, each one carries information. And some of that information is so specific that a physician can use it to identify a condition that has not yet produced a single symptom anywhere else in the body. The problem is that almost nobody has ever been taught how to interpret it. The conversation rarely happens during the average medical visit. There often isn't enough time, or the subject feels uncomfortable, or physicians assume patients already know what is normal. As a result, decades go by and people flush away this daily record every morning without ever looking at it. Not because they are careless, but because no one ever told them it was worth paying attention to. That changes today. Over the next several minutes, I'm going to explain what your body may have been trying to tell you through that daily record. We'll discuss what normal actually looks like, what common changes may mean, which colors deserve immediate attention, and which ones usually do not, and which stool shapes, when persistent, should prompt a visit to your physician without delay. By the end of this video, you will have a framework that many people go through an entire lifetime without ever learning. I encourage you to stay until the end because the most important sign, the one I believe is most frequently missed and most often misunderstood, is something I will discuss later, and it has the potential to completely change the way you think about this subject. I'm Dr. Mandel, and one question has guided much of my clinical thinking throughout my career. What is the body already trying to tell us? Not the dramatic symptoms that send people to the emergency room. Those usually take care of themselves. I'm talking about the quiet signs, the ones that appear weeks or even months before anyone begins paying attention. If this is your first time visiting the channel, I invite you to subscribe. I publish new videos every week, and I believe that important health topics deserve more than a superficial explanation. This is certainly one of them. Before we can discuss what is abnormal, we first need to understand what normal looks like, because you cannot recognize a departure from normal if no one has ever explained what normal actually is. And when it comes to this topic, most people genuinely have no baseline. What you want to see on most days is stool that resembles a sausage or a smooth, slightly curved log. Soft but formed, not watery, not crumbly, not so hard and compact that it is difficult to pass. Ideally, it should pass without significant straining, without discomfort, and without leaving you with the unpleasant sensation that you haven't completely emptied your bowels. And it should be brown. That brown color is not accidental. It has a very specific biological origin. Your liver produces a digestive fluid known as bile, which is stored in the gallbladder and released into the small intestine whenever you eat foods containing fat. Bile helps break down fat so that they can be absorbed through the intestinal wall. Interestingly, bile is actually green at its source, distinctly green, not pale green, not muted green, a genuine, noticeable green. If you could observe it when it is first produced, it would probably look nothing like something you would expect your body to make. But bile travels. It moves through the entire digestive tract, a distance much longer than most people realize. As it moves, bacteria interact with it. Digestive enzymes continue to work. Complex chemical reactions take place. And when everything proceeds as it should, when transit time is appropriate, when intestinal bacteria are functioning properly, and when nothing is accelerating or slowing the process excessively, the final result is brown, the color we recognize, the color that tells us the digestive system has completed its work as intended. Soft, formed, brown, passed without straining. That is your baseline. Keep that picture in mind because everything else I discussed today represents a departure from that baseline in one way or another. The first thing most people notice when something seems unusual is consistency. Whether stool is too hard or too loose. And those two extremes often tell very different stories. Hard, dry stool that breaks apart into small pellets, often compared to pebbles or rabbit droppings, usually means that stool remained inside the colon for too long before being passed. One of the colon's primary functions is to absorb water from the material moving through it. That is both normal and necessary. However, when intestinal transit slows down, the colon continues removing water beyond the point that is helpful. It keeps extracting moisture. As a result, what was once soft and manageable becomes dry, compacted, and difficult to pass. Mechanically, this is constipation. But the word itself doesn't fully capture what is actually taking place. Constipation may result from dehydration, something that becomes increasingly common after the age of 60 and is frequently underestimated. Many older adults consume far less water than they realize, partly because the sensation of thirst becomes less reliable with age. Thirst is already an imperfect signal in younger adults. It becomes even less dependable later in life. Low dietary fiber can also contribute, as can certain medications that slow intestinal motility, including some blood pressure medications, certain pain medications, and iron supplements. Another contributing factor may be diverticular disease, a condition in which small pouches develop within the wall of the colon over many years, often related to insufficient fiber intake. These pouches can occasionally trap stool and interfere with the smooth movement of intestinal contents. What many people do not realize is that hard, pellet-like stool is not merely uncomfortable. Over time, repeated straining increases pressure within the colon and pelvic floor, leading to additional complications. It can worsen hemorrhoids, it can weaken pelvic floor muscles, it can cause small tears in the tissue surrounding the anus, making future bowel movements even more painful and difficult. It becomes a self-perpetuating cycle. At the opposite end of the spectrum is diarrhea. And here I want to be very precise because there are two forms that people often treat as identical when they are not. Loose stool lasting a day or two after a heavy meal, a course of antibiotics, a stomach virus, or food that simply didn't agree with you is often the digestive system reacting to a temporary disruption and correcting itself. The body has systems designed to handle temporary disturbances, and in most cases they work remarkably well. Rest, adequate hydration, and a little time are often all that is needed. Most of the time the problem resolves on its own. But diarrhea that persists for more than 4 weeks is an entirely different situation. At that point, the body is no longer simply adjusting. It is failing to return to its normal baseline. And the reasons behind that failure can vary widely. Chronic inflammation of the intestinal lining may be responsible. A parasitic infection that the immune system has been unable to clear may be the cause. And in some cases, a tumor somewhere along the digestive tract may be irritating the intestinal tissue and disrupting the normal rhythm of movement. None of these possibilities improve simply because enough time passes. If loose stool has become part of your daily life for an entire month, the solution is not a different probiotic. The solution is a physician who can investigate why your digestive system has not returned to normal. Color is where the digestive system leaves some of its clearest clues, and it is also the area where most people have virtually no framework for interpretation. Green stool is probably the color that worries people the most, when in reality it often shouldn't. A diet rich in leafy green vegetables such as spinach, kale, broccoli, or any deeply green food can easily shift stool color in that direction without indicating anything serious. The chlorophyll contained in these foods may simply be present in sufficient quantity to influence the final color. Green stool can also occur when food moves through the digestive tract unusually quickly, not allowing bile enough time to complete its transformation from green to brown. The journey becomes shortened and the color remains green. On its own, this is not usually dangerous. However, if it continues to occur without an obvious dietary explanation, it is worth mentioning to your doctor, as it may suggest that your digestive tract is moving material faster than it should. Pale stool is much more clinically significant. Clay-colored stool, yellowish stool, or stool that appears almost chalky and contains very little of the brown color we expect deserves careful attention. When stool lacks its normal brown color, it usually means that bile either failed to reach the intestine in adequate amounts or was not produced properly in the first place. Brown comes from bile. If bile is absent or unable to reach the intestine normally, the stool reflects that absence. The possible causes range from a blockage in the bile ducts, to liver dysfunction, to disorders involving the pancreas, which plays an essential role in fat digestion and works closely with the bile system. A parasitic infection known as Giardia can also produce this exact type of pale, greasy, foul-smelling stool. None of these conditions can be reliably expected to resolve on their own, and none should simply be dismissed as a dietary issue. Sometimes pale stool is accompanied by another important feature, a fatty or greasy appearance. You may notice stool that appears oily or leaves an oily ring floating in the toilet bowl. This condition is known as steatorrhea. It indicates that fat is not being absorbed properly. Fat that should have been broken down and absorbed through the intestinal wall instead passes through the digestive tract unchanged. This may occur because the pancreas is not producing enough digestive enzymes, because there is insufficient bile, or because of diseases affecting the intestinal lining itself. It is not a dramatic symptom. Most people notice it briefly and think little of it, but it is a meaningful sign that something may be interfering with fat digestion and it deserves medical evaluation. And then there are two colors that should immediately overcome any hesitation you might have about seeking medical attention. The first is black stool, not dark brown, which is common and usually harmless. Black, the color of tar, sometimes thick, sticky, and accompanied by an odor that is unusually strong and distinctly different from what you consider normal. When stool looks like this, what you are often seeing is digested blood. When bleeding occurs in the upper digestive tract, the esophagus, stomach, or the first portion of the small intestine, the blood travels through the entire digestive system along with everything else. By the time it leaves the body, it no longer resembles blood. It has been transformed into something dark, thick, and unmistakable. Possible causes include bleeding stomach ulcers, severe gastritis, and a condition known as esophageal varices, enlarged blood vessels within the esophagus that can rupture, often in association with liver disease. Any one of these situations constitutes a medical emergency. This is not something to monitor at home. It is not something to casually attribute to the iron supplement you recently started. Although iron supplements can darken stool, they do not produce the tar-like appearance and distinctive odor I have just described. If your stool is truly black and tar-like, you should seek medical evaluation immediately, preferably on the same day. The second warning sign is bright red blood. Blood that is clearly visible in the toilet bowl, coating the outside of the stool, or appearing on toilet paper after wiping. This type of bleeding usually originates from the lower portion of the digestive tract, the sigmoid colon, the rectum, or the tissue near the anal opening. Because the blood has not traveled very far, it has not undergone digestion. It remains bright red. Hemorrhoids are a very common and usually benign cause of this type of bleeding. And I want to be fair about that because hemorrhoids affect a large proportion of adults over the age of 60. Most of the time when there is visible bright red blood, hemorrhoids are indeed the explanation. But I want to be direct with you. Hemorrhoids are also the diagnosis many people assume without any real evaluation, when in fact no assumptions should be made at all. Polyps bleed. Colorectal cancer bleeds. And one of the reasons both of these conditions can remain undetected for months or even longer is that people notice red blood. Remember, they have had hemorrhoids in the past, and immediately categorize the symptom as something familiar. I have seen this pattern far more times than I would like. Visible bright red blood should be evaluated by someone who can actually identify the source. It should not be diagnosed by guesswork or by process of elimination from the outside. I want to pause here for a moment. My father was not a man who used more words than necessary. He grew up in Beirut in a household where people spoke deliberately, where you thought carefully before speaking, and where you named only what you knew with certainty. He carried that principle throughout his entire life, and he passed some of it on to me. In medicine, perhaps more than anywhere else, those principles matter. Be specific. Be accurate. Do not name what you have not examined. I am explaining all of this not to frighten you. I want to be honest about that. My goal is to give you the language and understanding you need so that if you encounter these signs, you can recognize them and act appropriately rather than react with fear. I want you to recognize them with the calm that comes from understanding what you are seeing. Now I want to discuss what I consider the single most important point in today's entire conversation. Not color, not consistency, shape. More specifically, stool that is persistently thin, narrow, or flattened. Some people describe it as ribbon-like. Others say it is as narrow as a pencil, a finger, or even a crayon. I am referring to stool that has changed in width from what has always been normal for you, and that change has persisted. Not once, not on a single unusual morning, but consistently day after day, week after week. This is the sign that I see missed most often. Not because people fail to notice it. Many people do notice it. The problem is that they simply do not know what to make of it. It does not appear dramatic. It usually does not hurt. It often does not bleed, and so it is quietly dismissed. I need you to understand a little about the anatomy because once you do, everything else becomes easier to understand. The colon is essentially a long, hollow tube approximately 5 feet in length that loops through the abdomen in a very specific pathway before ending in the rectum and anal canal. The interior diameter of a healthy colon is normally wide enough that stool passes through it in a full, rounded shape. Like any hollow channel, the shape of the tube influences the shape of whatever moves through it. When something changes the interior of that tube, when something presses on it from the outside, grows within its wall, or narrows the space inside it, then whatever passes through becomes narrower as well. The stool begins to look different because the space available for it to travel through has changed. Persistently pencil-thin stool is your body's way of telling you that something may have altered the shape of that passageway. There are certainly benign explanations. A chronic anal fissure, which is a small tear in the delicate tissue near the end of the anal canal, can create scarring that narrows the opening. Diverticular disease may occasionally alter stool shape. External pressure from nearby structures can sometimes contribute as well. These are all genuine possibilities, and any physician evaluating you will consider them. However, persistent pencil-thin stool is also one of the recognized early warning signs of colorectal cancer. I use the word early very deliberately, and I want you to hear that word clearly. This change in stool shape often appears before pain develops, before unexplained weight loss occurs, before many of the symptoms people commonly associate with a serious illness begin to appear. In other words, your body may be providing this warning while the opportunity for successful treatment is still very much available. While the situation is still manageable, I want you to appreciate the significance of that. If you have been noticing this change, if the width of your stool has changed and remained different, if you have quietly been monitoring it while reassuring yourself that it will eventually pass, please allow a physician to determine what is causing it. Not a search engine, not your best guess. A physician who can examine you and, if necessary, look directly inside. Over years of medical practice, I have come to recognize that these signs rarely appear in isolation. The body tends to send messages in clusters. When there is a structural change within the colon, when something is narrowing that hollow tube, other symptoms often appear alongside it. You may notice a persistent sensation of needing to have a bowel movement, even when very little or nothing at all is passed. You may feel a constant sense of pressure, an uncomfortable feeling that your bowels have not completely emptied. Clinicians refer to this sensation as tenesmas. It can resemble constipation, but unlike ordinary constipation, it does not improve with the usual measures: more fiber, more water, or increased physical activity. The sensation keeps returning, because it is not being caused by something you ate. It is being caused by a physical presence within the rectum or lower colon that your body continues to detect. You may also begin to experience a form of fatigue that is distinctly different from ordinary tiredness. Not the type that improves after a good night's sleep, a heavier kind. A fatigue that quietly settles into your daily life without an obvious explanation and refuses to lift. When the body loses small amounts of blood, slowly over weeks or months, quantities too small to be visible in the stool, anemia can gradually develop. The red blood cell count slowly declines. The body compensates for a period of time, as it often does, but eventually that compensation is no longer enough. And when that happens, the fatigue that emerges is often unmistakable. It is persistent, flat, unrelieved by rest. You may also notice pallor. You may simply look different. The people who know you well may comment that you seem paler, less vibrant, or somehow not quite yourself, even if they cannot fully explain why. Another symptom that deserves attention is abdominal discomfort that repeatedly returns to the same location. Unlike ordinary gas or indigestion, which tends to move around and eventually disappear, this discomfort often has a fixed address, a dull ache, the same place again and again. Unexplained weight loss is another important sign. Not a few pounds lost because you have been eating less, but a gradual, unintended reduction in body weight that neither you nor anyone in your household can adequately explain. None of these symptoms alone establishes a diagnosis. I want to be very careful about that. Each of these findings can result from many different conditions, most of which are considerably less serious than the diseases we have been discussing. However, when several of these symptoms occur together, particularly alongside persistent changes in stool shape, persistent bleeding, or both, they deserve prompt medical attention. The body rarely sends every warning sign at once. More often, it accumulates them quietly, one signal at a time, waiting to see whether you are paying attention. Let me be very specific about when I want you to stop waiting. Black tar-like stool, even a single episode. That is not something to watch for another day or two. It warrants a same-day call to your physician or a same-day visit to an emergency department. Bright red blood that you cannot confidently attribute to a previously confirmed and currently active hemorrhoid should also be evaluated. Even if you have had hemorrhoids in the past, if the bleeding is new, heavier than before, or different in any way, do not make assumptions. Have it examined. Stool that has remained consistently narrow or ribbon-like for more than 2 or 3 weeks, especially if accompanied by any of the additional symptoms I have described, also deserves evaluation. 2 or 3 weeks is not a long period of time. If the pattern has persisted that long, it has earned a conversation with a physician. For any of these situations, the appropriate next step is evaluation by a physician, who can refer you when necessary to a gastroenterologist or a coloctil specialist. In many cases, a colonoscopy will be part of that evaluation. And I want to say something about colonoscopies. I have watched many people postpone them for years because they felt uncomfortable with the idea. Unfortunately, by the time some of them finally agreed to undergo the procedure, the conversation had become very different from what it could have been earlier. A colonoscopy allows a physician to directly examine the inside of the colon, not infer what may be happening, not estimate it from imaging, actually see it. And when a colonoscopy identifies a polyp, which happens frequently in adults over 60 because polyps are common, it can often be removed during the same procedure. A polyp that is removed before it becomes cancer is not a cancer story. It is a prevention story, and those are entirely different outcomes. One occurs because someone chose to investigate when the signs suggested that investigation was warranted. After the age of 60, a colonoscopy is usually far less frightening than its reputation suggests. The preparation is certainly inconvenient, but the procedure itself is generally performed under sedation, and most patients remember very little of it. What it provides in return is information. Real information, direct information about what is happening inside your body rather than an educated guess from the outside. When the signs we discussed today are present, that information is not optional. Waiting until you feel more certain before agreeing to be evaluated is often precisely how certainty becomes more difficult to obtain. Before I finish, I want to connect one final idea. Earlier we discussed pale or clay-colored stool and explained that the normal brown color comes from bile, which is produced by the liver. When the liver is under stress, when it has accumulated damage or excess fat over many years, bile production and bile flow may change. The quality and quantity of bile entering the small intestine can be affected, and when bile changes, stool often changes with it. The pale or chalk-colored stool we discussed earlier is in many cases a downstream reflection of what may be happening upstream in the liver. In a previous video on this channel, I discussed this very system. I talked about fatty liver disease, what gradually accumulates within the liver over years and decades, and about certain naturally occurring bitter compounds found in plants that have been studied for their potential to support liver function and regeneration. If today's discussion about pale stool, impaired bile flow, or the liver's role in digestion captured your attention, that video belongs alongside this one. The connection between what you see in the toilet and what may be occurring within your liver is much closer and more direct than most people have ever been told. The link can be found below this video. And I want to leave you with one final thought. Every single day, your bathroom provides you with a physical record of what has been happening inside your body. Most days, that record will reassure you that your digestive system is quietly doing exactly what it should. Most of the time, you will see what you expect to see, flush, and move on with your day. But on the days when something is different, a color you have never seen before, a shape that has changed and remained changed, or blood where there was none before, you now have a framework for understanding what you are looking at. You know which signs deserve attention. You know which signs should not be ignored. And you understand the difference between a body that is simply adjusting and a body that is asking for your attention. Your body has been leaving you these records for years. Today, you learned how to read them. I'm Dr. Mandel.